And I'm going to introduce first the guest moderator for the session, who's going to introduce the panel. Dr. Paul Charlton is the Emergency Department Director at Gallup Indian Medical Center. Dr. Charlton completed his residency up at the University of Washington. He's a friend of the consortium, a close colleague, and for those folks who work in the Southwest region, I think everyone at this point knows who Dr. Charlton is. And at this point, at 8:15 Pacific time, I'm going to go ahead and turn it over to Dr. Charlton for the panel.
Great, thank you, Sean. I will turn this, oh, there we go, the video is coming on right now. So nice to see everybody this morning. Thank you for the opportunity. I'm really proud, like many of the others on this call, to be part of the community of people that are very smart, well-trained, and really motivated about working in some of these extremely rewarding settings within the Indian Health Service, the tribal hospitals, and other rural sites. So thank you for the opportunity to be part of this today. Our panel is talking about some of the positive innovations that came out of the significant strains that many of our hospitals underwent last year. And many of the things that occurred changed us, not always in the best ways, but sometimes in very promising ways that were kind of unexpected. So we will have the panelists sharing their experiences from a variety of different sites. So joining us on the panel today, we have Dr. Topher Gentoff, who is the Deputy Medical Director of the White River Service Unit Indian Health Service Hospital in White River, Arizona. He's also the Medical Director of the White Mountain Apache Tribal EMS System. Joining him from White River is Dr. Dom Maggio, who is the Medical Director at the White River Hospital Emergency Department. From Northern Navajo Medical Center in Shiprock, New Mexico, we have Dr. Jeannie Ringelberg, who is the Director of their emergency department there. From the Gallup Indian Medical Center Emergency Department in Gallup, New Mexico, we have Dr. Safia Rubai, who has been, is one of the ED physicians here with a tremendous amount of experience, who has been the main liaison with all of the different relationships and coordination that has gone on within the hospital, within the state for the emergency department. And Dr. David Cheever, another emergency medicine physician who's been spearheading many of our social emergency medicine topics and has learned far more than any emergency physician should about how to correctly fill out IHS paperwork. And then joining us from the Brigham and Women's Hospital is Dr. Christopher Baugh, who's the Vice Chair of Clinical Affairs in the Department of Emergency Medicine at Brigham and Women's and an Associate Professor at Harvard Medical School. So thank you all for joining us today. I think we'll start with Dr. Maggio and Dr. Gentoff from White River about one of your innovations that we're excited to hear about. You had a unique program that emerged from this last year that you had titled your high risk team. And I'm hoping that you guys could tell us about that.
All right, I can begin. He's having some technical difficulties. Paul, can you hear me okay?
Yes, I can. Thanks, Dom.
Wonderful. Thanks for the patience. So my name's Dominic. I'm the ER director. I'm flattered to be here and thank you for the invite and for coordinating all this. So essentially at White River, we very early on got overwhelmed by the number of cases of COVID in the community. It was similar to the Navajo Nation in terms of prevalence of disease. And early on, our public health department became highly integrated with the emergency department operations and response and developed a high risk team that would essentially go out into the field, and anyone who tested positive, they would monitor at their homes. So if you met certain criteria as being high risk from a COVID illness perspective, BMI, age, comorbidities, our tracing team would identify you. You would make it to the quote high risk list, and then Dr. Gentoff and his colleague, Dr. Close, would coordinate a home team to essentially do daily to every other day pulse ox checks as well as symptom checks at home. They could bring patients medications, etc. And this would include a exertional oxygen saturation. So They would evaluate patients in the field, and essentially if the patient was hypoxic or had hypoxia on exertion, they would call the emergency department and send them in for evaluation. We found that this early intervention was very successful because we got our patients in for therapy as well as oxygen. And a lot of us have experienced the kind of silent hypoxia, that we saw with COVID, where essentially just a delayed presentation with people profoundly ill. So that's a big operational change, this integration of the high-risk team and high coordination with the emergency department. That continues today. And Dr. Gentoft, he's having some audio difficulties right now, but he was one of the coordinators for that team. The way it exists today and the way that we're expanding is that a public health department, it had always existed in a certain fashion at White River, but it's now become coordinated into a unique department. And essentially, in addition to continuing to do high-risk visits in the field, they have expanded. They're taking care of hospital discharges from transfer centers. They're taking care of hospital discharges from our own institution. And then they're taking care of emergency department near-term follow-up. So essentially what that means right now, it's for patients who essentially left the hospital AMA or who have some respiratory complaint that go home. But we hope to expand this to anyone that you could see in the emergency department where the patient has something that you would otherwise bring back to the emergency department in 2 days. Very common in a rural setting because you don't have close-term primary care follow-up to say, hey, return to me in 2 days so we can check on your cellulitis, or that pyelonephritis you're just kind of on the fence about. So that's where the system is really shining, is that there's still this huge collaboration between the emergency department and the Department of Public Health, with one of our administrators, Dr. Gentoft, sitting on that team and coordinating continued care. So we very much will continue this into the future, and if anything, continue to expand its horizons. So that's kind of a brief summary of how it operates.
And Dr. Gentoft, do you have things that you want to add to Dom's introduction on that?
I'm sure I do, although unfortunately, due to technical difficulties, I have very little content of what Dr. Maggio said. I will briefly summarize that the program grew entirely out of contact tracing and concern for subjectively asymptomatic patients who are at risk due to significant comorbidities of rapid decline. So we trained community health representatives, as well as who worked for the tribe, as well as hospital-based pharmacists, nurses, health techs, MDs, DOs, NPs, and PAs to perform regular home health evaluations with resting and ambulatory and recovery pulse oximetry to link patients to further ER evaluation if they began to deteriorate. And we feel very strongly that this relatively unique contribution to the entire system of healthcare made a fundamental difference in reducing the degree of morbidity and, in fact, mortality from COVID in our particular region.
And can you say more about the ways that the people who were doing these home visits were selected in terms of which roles you decided should be eligible to help with this, and then which roles will be continuing with the program in its new forms going forward?
To a certain extent, it was all hands on deck, and there was, as we might discuss later, sort of a pan hospital approach where we we harvested any sort of trained professionals to work, but we also worked really closely with the tribal board of health and the tribal community health representatives, and basically trained people on the field evaluation of COVID, and so relied a lot on CHRs and health techs, and the tribe was able to hire a handful of folks through CARES Act funding. And under the supervision of Dr. Close, myself, one of our chief nurses, April Turkins, we were able to basically train people up to look for early ill COVID. I'm sorry, Paul, what was the other question?
No, I think that's that mostly answered it for the funding for this, and in terms of like the departments that are contributing to that. What have you guys worked out with the funding mechanisms up to now? And then in terms of like pursuing billing or other things, so there can be some income coming in from the home visits, have you had any breakthroughs with that?
So the funding, so there are two primary sources of funding for us. One is IHS, and because we are a solitary hospital for the entire nation, we have complete discretion to allocate resources. So the funding is basically our hospital employees. The CARES Act funding came in through the tribe to the community health representatives primarily, and it is clear to both parties there that this process of the home evaluation by CHRs is valuable enough that the tribe is now committed to ongoing support. So I don't really have any ongoing concerns for continuing funding. The Board of Health is committed to having a field team in place for the foreseeable future. As far as we are able to capture billing through some of the novel capacities that COVID has granted us in terms of being more flexible in our home health, although I will personally attest that that has not been a significant concern to me or any of the other people who are signing off on the notes, and frequently ignore the recommendations from our billers to put in the appropriate details. But the billing we're able to capture billing.
And then kind of in closing on this this topic, what ways do you anticipate it continuing going forward, and on which types of medical issues might this be utilized in the future?
Well, it's ongoing for COVID for sure, and for the foreseeable future, even though at relatively low levels. It is the ways in which it's going forward are it's being adapted now for high risk OB patients, for high risk emergency department discharges, high risk discharges from either our hospital or in particular outside facilities. So for instance, White River sits at about a mile altitude elevation, and a lot of our tertiary care facilities are closer to sea level. So there's a significant concern on discharge home. So we try and wrap them in and see patients within 24 hours of discharge. And then we're going to take the same model and apply it to more targeted outbreaks. I think the next big target is probably going to be approaching syphilis with field-based laboratory evaluation and treatment.
And how far away from the hospital will your teams be willing to travel?
We're wherever people are, and we've gone as far as an hour to an hour and a half. So those familiar with the region of Northeast Arizona, we've gone from from White River to as far as Taylor, Snowflake, and the surrounding outlying areas, which is 60 to 90-minute drive away.
Yeah, so very big area. Yeah. Excellent. So thank you guys. We'll circle back to you with a few more questions, and then if others in the audience do have questions, please post them in the Q&A, and we'll try to get those answered. I do want to ask Dr. Cheever and Dr. Rubai from GIMC to tell us a bit about one of the related programs that was also kind of a hospital community level of coordination that had not been existent pre-COVID. That dovetails a bit on what was just described from White River. So Doctors Cheever and Rubai, could you tell us about the hotel motel program that got started in Gallup?
Would be happy to, Paul. So I'll start, and then Dr. Rubai can add on to some of the ways in which we're going to continue the hotel motel program, as well as communication with some of our community resources. Just like Dr. Gentoff and Maggio were mentioning, this was a program that started out of a crisis situation in the beginning of COVID. So for those of you who are not familiar, so Gallup is a border town. It's located on the southeastern aspect of the Navajo Nation and then just north of Zuni. And as a border town, it has a huge number of benefits. So it's a very diverse place. It's a center of commerce for the Navajo Nation. It's a center for a lot of ceremonies for a bunch of different tribal groups. But it also has a lot of public health challenges. And one of the most significant public health challenges, or a couple of the most significant public health challenges, are related to housing. So we have a significant amount of homeless people within this area. And then also because alcohol is legal in Gallup and not on the reservation, it is a center or a place where you see a lot of intoxicated people within the population. And then within the 1980s and 90s, it was noticed that there was a huge amount of exposure related deaths that was both connected to the homeless population in Gallup, as well as just the level of alcohol use disorder among the town, among a certain subset of the population. And so there was social structures, institutions that were set up within Gallup to help to mitigate the risk of exposure deaths. And one of those was, so there was a collection of homeless shelters that were set up in the town, as well as a very large detox facility that we call NCI. This was in coordination, works with the coordination of the local police to essentially pick up people who are at risk of exposure and bring them to this detox center. And pre-COVID, depending on which section of the detox center you're in, there could be anywhere between 80 to 100 people a night who are at this particular center. This was set up while there was some kind of interaction between the emergency department, and a fair amount of our patients were being discharged to this detox center, or to some of the other local homeless shelters. There wasn't much coordination on the leadership level, and the processes were kind of independent. This was a big setup for potential problems in the beginning of COVID. And when we first started to see our cases rise so we had our first case in the middle of March, and then end of March, early April, we saw a case, 3 individuals who ended up in this large detox center. And over the course of a week to 2 weeks, they had exposed essentially 100 people. And then from there, we had an explosion of COVID cases throughout our community. That caused that large detox center to then shut down, as well as most of the kind of communal housing units and public housing units within the city. And all of a sudden we saw, as kind of the social area of last resort, or the social safety net of our community, all of these people who would otherwise go to the detox center or the homeless shelters end up in the emergency department. And saw a huge uptick in our COVID cases, but also our patient population as well. And we were reaching towards essentially kind of crisis levels, given this influx of patients. And so we went to our hospital administration. We went to and created essentially a multidisciplinary group within our hospital, with a bunch of the internal medicine physicians, as well as other stakeholders within the hospital who had experience dealing with lots of different groups within Gallup. We reached out to the New Mexico Department of Health, as well as the governor's office, COPE, which is the Community Outreach and Patient Empowerment. So that's a subset of Partners in Health, so an important NGO within our community, and was able to convince some of the local hotels and motels within our community. So initially it was 1 hotel, then it moved up to 3. Eventually we had 4 hotels that were involved in this program, and was able to create housing. And this was housing for patients who were deemed to be high risk for COVID-19 or had COVID-19. So for some people, it was had nothing to do with alcohol use disorder or their own homeless shelter. It essentially was just a place where they could self-isolate from their families because they had been exposed to COVID. But it was also a way that we could actually take this very high risk population, our alcohol patients with alcohol use disorder, and house them in a way that was safe with our detox facility still shut down. In June, kind of at the high point of this program, we had upwards of 150 people within these shelters at any given time. This program has continued, but in the interim, our detox facility has reopened, as well as increased coordination with the police and a lot of these like local NGOs and homeless shelters. And that is what's, I feel like, really important moving forward as we look towards what we can learn from this experience. And I think the things that have been really crucial with that is collecting data to justify continuing to have these types of programs, and then continued communication with these organizations. And the person who has really spearheaded that for our group is Dr. Rubai, who can talk a little bit about her interaction with this and how she's working to kind of continue this program moving forward.
Oh, thank you, David. I think you mentioned a lot about what was going on in our community. I wanted to emphasize that everything didn't start with the crisis of COVID. We actually, like everyone else who's here, we're very aware of the inequity and social problems that our patients have much before COVID. And I think COVID kind of really magnified that, so that we could really lay open all of our vulnerabilities. What we found really important was early on, actually many years ago, we had alcohol support for patients with alcohol and with homelessness. And over the years, our shelters have closed and opened. Our detox center has closed and then opened. We've lost funding, closed, then open. So the response to having this high number of patients at COVID risk in this really mini epicenter at the detox center really brought us into another stage. For the past 8 or 9 years, we had an alcohol community task force that was very well attended, and it had gone on, started and kept going on by Dr. Jenny Way, one of our internists who's very concerned about the public health needs in our community. And that alcohol task force had actually already been successful in getting a rehab center started here and involving the city of Gallup and McKinley County, and having representation from the other hospital in our community, as well as other players. When we moved into the pandemic arena, more people came into that task force that maybe normally weren't present. So we started having the involvement of the police, the jail, the Department of Health from the state of New Mexico. And it even had more attention paid with NCI, our detox center. And we were quite successful at even getting another detox center with a totally different model, a voluntary model, to open in the community. That alcohol task force that I referred to had also previously been very successful in getting a rehab center other than NCI, which also has long-term treatment going in our area too. So with the involvement of the New Mexico Department of Health, and with the involvement of the city, of the county, and other agencies, we found ourselves to be we were able to communicate really well. And I would say that the most important takeaway that I've received from our experience is the Navajo idea of A, which is relationship. To be working so closely with the director of the detox center, the chief of police, the city, the Department of Health, and to be able to say, hey, our emergency department is now overwhelmed. What can we do? We have no place that's safe for these folks to go, especially when it was moving towards winter. And as David mentioned, the problems we have with exposure. Well, people that you would not even imagine would be able to help were able to really come up with innovative ideas. Our detox centers started actually performing COVID testing. And although at first they were closed and then they could only take COVID negative people, they, with Dr. Way and the Department of Health and other folks' help, were able to figure out how they could accept COVID positive people as well, and then COVID recovered people. and then an area also for COVID negative people, although small, and not offering opportunities to women who are COVID negative. This relationship continued because with the police, for example, the police would be able to bring people directly to NCI instead of having them come to the emergency department. The police is also who runs the CSA vans that goes and looks in all the arroyos to see, are there any people who are at risk of exposure laying in those areas? So that part was actually really exciting, and that's continued. We have gone from twice weekly meetings and calling each other whenever we needed each other on the cell phone. I was going to say I talked to the head of detox probably more than I talked to my sweetheart on a daily basis on the phone. But it's also brought us into an area where now we're only meeting once weekly on Mondays. And then we've reserved the second day of the week to talk about high utilizers of the emergency department and what can we do to work with those populations and see what we can do to help them. So I would say that area of relationships is where we've really been able to move forward with our community, to really step into the community and be partners in the community.
Stafi and David, one of the things that comes through hearing you both speak is just how sustaining certain elements of this last year have been. Many of us in emergency medicine have trained at big urban public hospitals. And I think there's often a feeling that the only place that you can find that sense of being a safety net hospital for a very underserved community is in urban areas. And I think what you're describing there is showing that really is not accurate. And there is a lot to be said about the way that rural hospitals working in many of these communities that are equally underserved and often just overlooked within the broader field of emergency medicine can be prime areas for looking at and starting to address social inequities and being able to serve in safety net roles on some of these ways that are really meaningful and sustaining for people in emergency medicine. So thank you for highlighting that. So Chris, I might move to you from the Brigham and Women's side. So you're working in a different type of setting than what has been described from GIMC and then the White River Indian Health Service Hospital. But equally, many of the other hospitals have experienced innovations this last year that we're interested to know about. And I am curious to hear in particular about two things from your side. What type of front-end operational innovations have you made to try to help patients be safer as a result of some of these COVID stressors? And then I'm particularly interested to learn about the internal communications that you did around the operational changes within your hospital that helped people be on board to them rather than being frustrated by the frequent changes.
Sure, maybe I'll start with the communication strategy first. I think early on, our department leadership recognized that a communication strategy was going to be really important to help us, put our best foot forward and really get through this, both from a staff perspective and allowing us to take the best possible care of our patients. And I think in the early days, there was an overwhelming amount of information coming to us. We were getting emails from our hospital, from our health system, from the state, from the DPH. There were communications from CDC. And so I think and some of those communications were in conflict with one another and kind of reconciling what we're going to be doing on the next shift that we work was really confusing. And so the strategy that we set up is basically a system of daily communication where I took the lead in curating all of these messages, and then I would highlight the ones that would be most impactful to our care in the emergency department, and kind of reconcile to say, hey, I know this is what you may have heard, but this is what we're actually doing. And so the way we organized that was an email that would be sent off around 9 o'clock in the morning every weekday, and that email would have information that would be nominated via Google Doc that we maintained, and we'd have a small work group of about 10 leaders from nursing, physician staff that would have an evening phone call around 8 p.m. This was pre-Zoom, so this was a telephone conference where we would talk about what would go out in the next morning's message. And And that message would include kind of, like a bulleted list of updates. I tried to make it really digestible, that you could read it on your smartphone. And then it would also have actual data, like the number of visits we had the day before versus what our typical number of visits are, the number of patients who were PUI or confirmed COVID positive. I also included the number of ED intubations and the number of ICU extubations. And we did that for all of our 3 clinical sites. We have our main hospital, an affiliated community hospital, and an urgent care center. And I made sure to include service line leads outside the emergency department, like ED radiology or case management, so that we had kind of transparency. And there were many times when, the message is that we're not sure, but we're working to clarify. So kind of hold tight. And it was also a channel for people to ask questions back, because we would try to address their question in, say, the next day's communication. These messages all came from me, and so that was always something they would look for in their inbox. My signature at the end of the email had below my sign off the rest of the department leaders' names as well, just showing unity across all of the department leaders and all the sites. And then I felt like, as a leader, this was an opportunity for me as well to really signal a sense of unity and hope to our staff. I mean, this was, as we all know, it was periods of time where we didn't know how high the surges were going to be. We didn't know if PPE was going to be an issue. We didn't know how many of us would get sick. There was there was no certainty around a vaccine. And so I remember my usual email sign off is best, Chris, and that's what I do kind of all the time. And I started playing around with different ways to sign off on this daily message. I settled with something that I ended up using, during the whole April surge, and again in December, January, when we went back to this communication, which is strength and love. I mean, I just wanted people to feel that, right? That like we're united, and we need to be supporting one another. We need to be giving love to one another and our patients, and have a kindness to the way we were going about things. And I think that was well received. And as I mentioned, we kind of sundowned this daily communication, which was hard to keep up on a daily basis. In probably end of May, when it was clear that we were out of the woods for that particular surge. And then when this January surge in the Northeast was coming back, we kind of picked it up around Thanksgiving time through the end of January. But we did it as a weekly message at that point, just because we were much better prepared at that time. And there was a lot less uncertainty around things like PPE, vaccine, et cetera. Although, early on, vaccine access for staff, you can imagine in December, was like a huge point of confusion around scheduling vaccine side effects, eligibility, all that kind of stuff. And so this message was really like the way for that communication to be like really well articulated and streamlined. And I think our staff really responded to that. And for me, it was a good lesson in communication as a leader. Now, of course, like there were other ways that we communicated. We did daily in-person rounds in the emergency department to kind of emphasize some of the key messages. We had every 2 weeks a faculty meeting over Zoom. And so that was like a video Q&A that allowed people like a little bit more dynamic real-time communication. But the core of the communication strategy was this email. And in retrospect, I think it was good for us, and it's kind of ready to be stood back up if needed in the future for anything like this, if it comes around again. And then pivoting really quickly, I know we're kind of short on time here. Our front end. So we actually, in April, put a tent out in front of our emergency department, and we saw PUI in kind of open air in a tent, and then we created a booth to do swabbing. And that worked pretty well for us through that April-May timeframe. The weather in Boston generally was accommodating. I think in the winter, when it became clear that in November we were going to get another surge over the winter time, an outdoor tent in Boston was just going to be a non-starter. And so we ended up creating some space within the atrium of our main lobby that would be well ventilated and partitioned with plexiglass and spread 6 feet apart. That would allow us to have kind of an overflow waiting area in a safe way. And then we put a PA and 2 nurses and a medical assistant from 12 noon to midnight that could do care initiation. So they could see people for kind of simple things. They could treat and release. And this is without an emergency medicine attending seeing those patients, but the PA would be able to see them, and we only staff more senior PAs that we trusted with that. And then we, for other patients who need further care, they could have an IV placed. The PA would order labs, and then by the time the patients made their way back to the core of the emergency department, they would have already an IV placed, and they would have labs resulted. So that helped us pivot to immediately getting to a CT scan or a consultation or something else where maybe labs would have been a delay in getting some of that done, and that just helped reduce the amount of time patients were waiting where their care wasn't progressing in any way. And so we're still doing that now, and our ED is under a major reconstruction project right now, and we're actually going to formalize this workflow next winter when we open to have an actual suite of 7 rooms that go right behind our triage booths, where a PA and 2 nurses and a medical assistant, just in the same way they do this work now out of the waiting room, are going to have more proper space with closed rooms and a lot more privacy for patients to do a similar workflow in the future design.
And Chris, do you find that with the experience of what happened there over the last year and how much frequent change there was, do you find that your team now, the whole emergency department team, is more receptive to continue to evolve with different approaches, or are they more frustrated than they were a year ago because they're fatigued?
Yeah, that's a great question. I think because we actually had 2 shocks to our normal operations in the past year, which is the pandemic, plus I mentioned this redesign. We actually have been building for about 2 years now, and last December moved into new space, but then closed some of our previous space. And so right now we're kind of we're trying to make dinner out of a kitchen that's being remodeled, and half of it's done and half of it isn't, and it's really challenging. It requires a lot of flexibility. I'd like to think that that we are well enough staffed and have enough resources to where we've been able to support one another and have kind of an open mind. It seems like we have some leaders who, among different disciplines, who are very engaged and open to rapid cycling of different workflows, right? To say, hey, this isn't working, let's try something else. And we have leaders stepping up to work those shifts, the early shifts themselves. Like, when we opened the tent in front of our department last spring, myself, the lead PA, we're kind of taking the early shifts, and there were things that needed to be fixed that we thought we had on the first try that were clearly wrong. I think us being willing to kind of do that signaled to the rest of the group that that we're all in this together, and we're kind of interested in people's feedback and willing to make changes based on that feedback. And so I think people are going to look forward to next year when our department's completely built out, and fingers crossed the pandemic is in a much different place than it has been, that there'll be a bit more of a steady state. And so, but that being said, I think there are people who are tired. One of the big things that I've tried to personally do is just prepare myself for basically a marathon and not a sprint, in terms of the way I pace myself, the way I take care of myself. Just believing that I'm going to be more effective in my role if I feel like I'm getting good sleep, if I'm exercising, if my relationships are strong. Like, these are all things that are going to sustain me to be more effective over the long haul.
Great. Thank you. Thanks for sharing that and those tips. Dr. Ringelberg, I think, is back. Jeannie, do you want to go with? We've got about 8 minutes, and I would like maybe 2 minutes at the very end to do just a quick closing remark. But Jeannie, do you want to tell us about your Northern Navajo experience?
Yeah. Can you hear me?
Yes.
Okay. Great. Thanks, Paul. So I admit I can't take credit for this program, but I think it's worth highlighting just to give you a little background. So Northern Navajo Medical Center, we're a short-term acute care hospital. We have 56 general and 5 ICU beds, and we're located in the Four Corners area. We're one of 5 facilities in the Shiprock Service Unit, which is the largest service unit of the Navajo Nation. And we're about an hour and a half to Durango, Colorado, 2.5 to Moab, Utah, just over 2 hours to Telluride, and then longer drives of 5 and 4 hours to Sedona, Arizona, and Santa Fe, New Mexico, just to give you an idea of where we are. In March of last year, we saw the first cases or cluster of COVID on the Navajo Nation. And the first surge was in some ways a slow build for us compared to the second surge. And it peaked in May, but it gave us some time to build and improve our COVID response. Fortunately for us, at that time, Albuquerque, our major transfer city, did not initially see a lot of cases. And so we were able to transfer out all of our sick patients. However, like every other institution, human resources were still scarce, mainly nurses. And this resource, or really lack of resource, drove our hospital capacity. And we saw what was happening, in places like New York, and knew our small hospital may easily reach capacity and lead to crisis standards of care. So this program was really born out of necessity and fear. So at Northern Navajo Medical Center, we had a drive-up triage, and then we had a 3-tier system for COVID care based on triage to mild, moderate, and severe respiratory status. Those with mild symptoms but adequate oxygenation were seen outside and discharged, and those with moderate respiratory status were evaluated in the ED for possible admission or discharge with home oxygen. Obviously, those with severe respiratory status were seen in the ED for admission or transfer. So patients had to meet criteria for home oxygen. They needed to have, they needed to be less than 50 years old. They needed to have an oxygen stat of less than 90%. And then they had to require no more than 2 liters on nasal cannula. And then we actually had significant exclusion criteria. For instance, if they, still had dyspnea on their 2 liters nasal cannula, then they were excluded. If they had diabetes, congestive heart failure, liver disease, lung disease, chronic kidney disease, if they were pregnant, or if they didn't have a reliable phone for follow-up, then they were all excluded from the program. So our home oxygen vendor kept around 10 to 20 tanks and concentrators in a closet in our ED. And patients were sent home with what we considered these starter kits that included a sort of mini oxygen concentrator, a portable oxygen tank, and then oxygen setup with tubing and supplies, and as well as a pulse oximeter. Our ED providers placed the consult order for public health nursing to follow up with them, and then co-signed our nurse case manager and their note. And in the first surge, around 36 patients were enrolled. And admittedly, we were kind of hesitant. We were like, we don't normally discharge patients with home oxygen from the ED. And we were kind of cautious of how was this going to work? Were we sending patients kind of home to die in the middle of nowhere? But after the first surge, data showed that actually patients did pretty well. No one died. That age may not actually need to be firm exclusion criteria. Most patients required a kind of oxygen within 7 days of symptom onset and were off by day 14. But providers should have a low threshold to consider admission if the patient had another ED visit after starting home oxygen to go. So we actually, for our second surge, expanded our criteria to enroll patients 65 or younger and include those with diabetes, chronic kidney disease, and liver disease. And this mattered because the second surge saw us closer to crisis standards of care due to lack of beds, despite the fact that we had doubled our space in the ICU, opened our PACU for ICU beds, turned our PEDS and OB units into non-COVID beds and less actually needed for those patients, and turned all of our med-surg into a COVID unit. And in the second surge, we enrolled 137 patients. And just really discharging patients home with oxygen was only the first part of the program. The other parts included pulse oximeter monitoring, telephone follow-up, and when the patients, isolated for the 2 weeks, the 2-week period, patients were called daily by public health nurses. And then additionally, they received follow-up calls from a family medicine physician or APP until the patient no longer required supplemental oxygen to maintain a set of at least 92%. So that was kind of the logistics in terms of our home O2 program.
And then Jeannie, thanks for sharing that. Can you tell us more about how that contributed to the willingness of your department to take on more challenges going forward?
Um, yeah, I mean, I think, this was certainly an example of a need leading to implementation of a program in a unique setting, and then utilizing collaborative work, across multiple departments. We had actually utilized a similar model. We had family medicine doctors staffing our moderate COVID respiratory unit in our emergency department. So they were credentialed to work in the ED, could see both patients, could both see patients and admit them. And I think people saw, the success of that program, the success of the home oxygen program. And it was, okay, like, we can do this. We can do these things that we're not normally doing. And then if our innovation is risky, then we can plan for frequent, PDSA or plan, do, study, act cycles and intense follow-up. And then really also knowing that data helps, like allowing us to cautiously expand the program after the first surge, and then monitoring it after that. Again, we had one unanticipated death, but it was in a person who we sort of considered compassionate use of the program because they refused admission. And we had a couple of patients like that. It's hard because we haven't totally taken that model and applied it in the ED again, but I think it gives us hope that we can do that. And certainly we have a lot of issues that are coming up, for instance, figuring out how to best serve bariatric patients in our ED. And I think that we can utilize this model moving forward.
Thank you. One of the things, Jeannie, that stood out with one of your early comments was just the sense of commitment and responsibility that I think many of the emergency departments in the Indian Health Service and within the tribal 638 hospitals feel about our responsibility to provide optimal, full spectrum care for the patients that come through our emergency department, and that there's a sense of worry when patients from some of these communities do have to be transferred outside of our system, that sometimes those other systems in urban areas may not be as attuned to some of the social limitations, the logistical challenges of the home environments that people are coming from. We're aware that looking at the CDC and other public health data, the morbidity and mortality for Alaska Natives and American Indians who had COVID was much higher than for other races and ethnic groups. And a real sense of, we want to make sure that we are being strong advocates for our patients, that we are committed to fulfilling this very, very clear mission that is driving many of us to work in these settings, and that we want to make sure we're doing our part. And I heard that from GIMC, from White River, from your comments of just how much that comes through here. So thank you for highlighting that. So I think let's wrap up with this. What I'm taking from this is I think we have an innovation coming out of White River that again was new, was kind of courageous, more field-based, and is looking at ways to extend this emergency department level of expectations and commitment to our population, to take it outside of the emergency department into scenarios that would not have been invested in as much before. So that, seeing how that worked well in this setting, and then continuing it on other public health related issues that it has a lot of promise for. From GIMC, what I am hearing on this is this strong commitment to be looking at social issues that move through and affect the emergency department, and to say that we have a stake on this, and even if nobody else is taking the lead on it, people in emergency medicine can. And then from Brigham and Women's, this real importance of the daily communication and the approach to how to create an organization that is able to move forward with rapid change, and looking at innovations that do help keep people safer and things move more smoothly for optimal patient care. And then from the Northern Navajo experience, this sense of empowerment, willing to take informed risks, look at them very closely, and do what is needed in a setting of kind of innovation out of necessity. I think Sean has a question, and then I do want to pose one last question to all of the panelists, a very short one. But go ahead, Sean.
Thanks, Paul. Great discussion so far. I had a question for Chris Baugh, and I'm curious, Chris, from your vantage point and as an operational leader at a tertiary care center, an academic center, where you really, it's those types of places where I think the standards are set for operations and, of course, clinical practice. And so there's many emergency department leaders who are attendees for today's conference. So I had two quick questions, or guised as quick. The first is an operational one. When you talk about de-escalating or transitioning away from the adaptations you made for COVID in the front of the department, I'm curious what your triggers are and how you think about making those changes, because many of us have made these front house changes and we're just not sure when to quite scale back. And my second question is, in the wake of COVID, in the wake of this pandemic, do you see any changes in the standards of emergency department operations that we as more remote emergency department leaders need to be aware of? So a two-part question.
Sure. I think for the first part around kind of when to stand up and scale back, particular like front end operations in particular that are kind of dealing with either infection control, so isolation of patients, or surges of patients where we couldn't just routinely see them within the core of our emergency department through our usual processes. During we were kind of following the COVID surges very carefully, and we were doing quite a bit of modeling. We had some in-house folks who were very sophisticated with modeling, and we kind of had a worst case scenario, a best case scenario, and kind of an average of the two. And we were following that on a daily basis to get a sense of when to implement certain things, and then also when to back off. And we were looking at case counts in the community, the percent of tests that were positive, a lot of the same things that I'm sure other people were following as well. It's interesting, now we're kind of migrating as the vaccination rate gets higher, and the actual census of patients with COVID in our hospital is relatively trivial at this point. I mean, I think the whole hospital right now has maybe less than 10 inpatients who are COVID positive, but we're seeing this extreme kind of resurgence in use of the ED in the hospital now over the past, I would say, 4 to 6 weeks. The surgical schedule is full. Our ED visit volume has now returned to our pre-COVID levels, and so we're dealing with a full hospital now in our normal amounts of visits, and that's resulting in a lot of inpatient boarding and crowding. And so now we're kind of doing this front end out of necessity, not because of a COVID surge, but because of routine volume that has kind of returned to normal. And this is, again, in the setting of being halfway through a redesign project. And as a result, it's kind of our new normal at this point. If our hospital inpatient service wasn't 100% full or over 100% many weekdays, we probably would wind down that front end. And so the solution probably depends on kind of what your COVID volume looks like and what your inpatient census and boarding looks like in terms of triggers to wind things down. Because we look at our waiting room length of stay, we look at our walkout data, and we're looking at also elopements now too, because our front end operation is basically transforming a lot of left without being seen into elopements, because they've been screened by a PA, they had an EMTALA evaluation, and then they walk out. That's still, to me, a failure of our system. And if we're not tracking those as well, then we're kind of missing the big picture. And that's been a change since we've implemented our care initiation on the front end. And then, Sean, just prompt me again, the other part of your question.
Sure. Are there any changes to the standards of ED operational practice that you think we might need to be aware of moving forward? Has the entire House of Emergency Medicine operations shifted in any way?
I've thought a lot about that over the past few years as we've done this redesign project around this concept of super tracks affiliated with triage. Is triage more of like a check-in with moving a lot of the things that a triage traditionally does to the bedside nurse once the patient's moved to a care area, to minimize kind of the queue for triage, and then triage itself being kind of more streamlined? the role of APPs and the way that they interact, either independently or in conjunction with a physician, that's evolving as well. We're kind of facing that in our own academic center as our support with resident staffing is only decreasing over time as our ED visits increase, and we have to decide whether that means more APPs or more independent practice of the physicians. And this is at an academic center where the physicians are very used to co-managing patients with trainees, and that's now going to be probably the exception to the rule in the future. These are all things that are evolving over time. I don't know how much of what we've seen in the past year just related to COVID is going to stick around, other than kind of now a memory and an experience of leaders around how to better coordinate, communicate, and manage surges. One other example that came to mind around kind of coordination of care was, the Boston Marathon bombing in Boston, and how the different hospitals kind of came together to distribute patients and to coordinate with one another. That was a very different thing in that it was it was essentially like a 6-hour event rather than a multi-year event, which COVID is. And so a lot of the lessons I think learned from that experience probably didn't stick around because it was such a transient thing. I'm hoping that the coordination, especially with respect to access center, we didn't really get into that today, but around distributing patients and load leveling, really does transform the way that patients move between hospitals and essentially get to the right level of care. And that could mean a two-way street between patients who need tertiary care getting from community hospitals in a more efficient way, and also patients who would get great care in a community hospital moving from a tertiary care hospital back into the community setting to create more bandwidth at those tertiary hospitals to care for more complex patients.
Great. Thank you. So we've been granted 1 more minute. And in that time, I would like to ask each of the panelists to give, what's your 1-sentence piece of advice that you learned from this innovation that you described before? We'll start with Dom.
Collaboration across departments is key. And it's really surprising what you can accomplish by doing that.
Great. Topher?
Collaboration with outside of the hospital with tribal agencies and the tribal government is absolutely essential and foundational for trust between not just the organization, but the people whom we serve and us. And that is absolutely essential to patient care.
Thank you. David?
That there's real benefit to embracing the emergency department's role as a social safety net, especially in rural areas, and then finding a way to deal with these social issues within the context of your normal ED processes.
Thank you. Safia?
Speak up, ask for help, give help. Never, ever, ever give up. Even if you try and try and try and you don't get the results you want in the desired time, don't give up.
Thank you. Chris?
Streamlined, honest communications with a predictable cadence and a message of hope to your staff.
Thank you. Jeannie? And if Jeannie had to drop off again, thank you to all the panelists for sharing your experiences today. And thanks to the whole organization for the opportunity.